Ladies and gentlemen, may we request all of you to please be seated so that we may resume the session on time. Please ask your friends outside if they could come in and sit. Ladies and gentlemen, we will resume the session, and for the third session, we will request our moderator, Dr. Asif Beg.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. This is Dr. Muhammad Asif. I'm moderating this session, right? So it's a post-lunch session. So it's a post-lunch session, and most of the time this is the most difficult session to concentrate because of after the lunch. So let me introduce our panelists first. The first panelist is Dr. Muazzamuddin Ahmad. He's a professor of medicine and gastroenterology. He's a renowned, experienced physician. May I ask him to please come in the stage and take his chair, right? So thank you, Dr. Muazzam. The second person is Professor Amjad Salama. He's a renowned gastroenterologist, currently practicing in the biggest hospital of the world in Islamabad. I will ask Dr. Professor Amjad Salama to take his seat, right? The third panelist, our international guest, Dr. Bilal Hamid. He is a renowned hepatologist, traveled from the US for this conference. Dr. Amma Subhan, I guess she will join later. So we will start with our first talk The first talk is all about the management of the hepatitis B guideline in the light of the new guideline and any new changes in the hepatitis B management. I will ask respected Professor Javed Iqbal Farooqi. He is a very famous ex-president of PSH and renowned professor to get some light on the hepatitis B management. Thank you, sir.
Bismillah ar-Rahman ar-Rahim. Thank you for the kind introduction, or good afternoon. Few people, I hope के बाकी colleagues भी आ जाएंगे. Well, thank you very much, Feroz Sons, with this unique honor. This is the 12th Liver Summit, and Alhamdulillah, I've been the part of each and every one. बहुत सारे मेरे colleagues हैं, सलीम भाई हैं, असद भाई हैं, लेकिन मैं और अरुण, we are the, हमीद साहब भी थोड़ा सा, बिलाल भाई भी थोड़ा लेट हम ज्वाइन किया. We have been the only two के जो सब में रहें, लेकिन यूनिक ये है कि अब पिछले 3 में अरुण भी ऑनलाइन हो जाता है. तो thank you once again for Feroz, your confidence on that. I think this is most अच्छी बात तो ये है कि कोई डेटा नहीं है इसमें, ना कोई मैं आपके साथ कोई जो पेपर्स हैं वो डिस्कस करूँगा. सिंपली जो हम रूटीन में करते हैं, स्पेशली फॉर माय यंग कॉलीग्स, जो हम क्लिनिक में होते हैं, पेशेंट आ जाता है और हाउ वी गो अबाउट. तो बेटे कौन सा वाला आगे जाएगा? ओके. So the management of HBV in the light of new guidelines, we know there's been plethora. शायद हमारी पैथोलॉजी में यही एक डिजीज़ है कि हर साल हमें अपने ट्रीटमेंट प्रोटोकॉल्स में कुछ ना कुछ चेंज, फाइन ट्यूनिंग करनी पड़ती है. एंड दिस इज़ फॉर द रीजंस के ऑलमोस्ट तकरीबन हर साल किसी न किसी बिग बॉडी से, चाहे AACD है, चाहे ईजल है, चाहे वो अपाजल है, WHO से एक गाइडलाइंस आ जाती है, और फिर हमें थोड़ा सा अपनी प्रैक्टिस को फाइन ट्यूनिंग करनी होती है, उसमें कुछ चेंज लानी होती है. स्पेशली जब लास्ट 4 गाइडलाइंस 2023 में जब चाइनीज़ गाइडलाइंस आई, 2024 में WHO आई, और इसके बाद फिर लास्ट ईयर ईजल, और फिर दी कपल ऑफ मंथ्स अगो AACD की जो आई, इसने नेचुरली, और जब WHO के टारगेट आया कैट 2030 हेपेटाइटिस एलिमिनेशन BC फ्रॉम द वर्ल्ड, तो नेचुरली ये चीज़ हमें बियॉन्ड भी जो रूटीन में हम जा रहे होते थे, अब तमाम गाइडलाइंस पहले थोड़े दीज वो दी कि इफ़ इट इज़ इंडिकेटेड ट्रीट दिस पेशेंट्स, अब आ रहा है कि इफ़ इट इज़ कॉन्ट्राइंडिकेटेड डोंट ट्रीट अदरवाइज. वो कैनवस बढ़ा रहा है कि किन किन को हमने इंट्रोड्यूस करना है. सो इन माई दिस 15 minutes or so talk, if a patient comes to me in my clinic, so the 2 main questions: when to start treatment and when to stop treatment. और इसी को जवाब हम ढूंढेंगे कि जो गाइडलाइंस हैं और हाउ आई एम ट्रांसलेटिंग दोज इनटू माय क्लिनिकल प्रैक्टिस इज, पेशेंट आया, उसके हाथ में HBs एंटीजन पॉजिटिव का एक टेस्ट है. अब आया, इसको मैं ट्रीट करूं या इसको ट्रीट ना करूं, और इसको फॉलोअप में रखूं कि कब उसको ट्रीटमेंट की ज़रूरत पड़ेगी. यही क्वेश्चन, इसी को हम आंसर करने की कोशिश करेंगे. देयर शुड बी नो रिफ्लेक्स एक्शन कि जी HBs हुआ, PCR करो, बस इलाज करो. वी शुडंट फॉरगेट आवर बेसिक्स ऑफ क्लिनिकल मेडिसिन, and that means detailed medical history, of course the physical examination and investigations का रोल उसके बाद में आता है. उमूमन बदकिस्मती से मेरे पास पेशेंट आ जाते हैं, HBs भी होता है, साथ में PCR भी होता है, उस कोलीग ने कुछ भी नहीं किया होता जी, बस यार कुछ ज़रूरी होता है, बिकॉज the decision of whether I need to treat or not is not that simple. So important is कि okay, चलो आ जाए. Well, history में mostly we know the basics of the patients, the age is important, uski family history is important. ये जो उसको एज-बेस्ड एंटीजन पॉजिटिव आया है, whether he has presented to us, it was a case of acute hepatitis, या previously कोई hepatitis की history थी, नहीं थी, how the patient was found to be having age-based antigen positive, उसकी कोई family history है कि नहीं है, hepatitis B in the family आया, उसकी कोई cirrhosis की history family में है कि नहीं है, B related, कोई liver cancer की history है कि नहीं है. All these are very important because until and unless you have this data, आपको आगे जाके जिसने help out करने. So we know age of the patient is important. बाद में देखेंगे why this is important. Has the patient presented with acute hepatitis? Any history suggests acute hepatitis in past? If not, how the patient was found to be positive? Screening थी, कुछ और reason था. Liver cirrhosis patient may come कि जी मुझे कोई bleed भी हुआ था या वो भी होता, तो they come. Maybe they would just check the test. Otherwise, उनकी history आपने लाजमन पूछनी है. And of course, any co-infections अगर known है, comorbidities like diabetes, fatty liver disease, family stuff, liver cancer, all those, and either the patient is on immunosuppressive therapy or extrahepatic manifestation. All these information is important to get with you because this will help you out. स्पेशली उन केसेस में कि जो ग्रे एरियाज हैं कि आया आपने इस पेशेंट को ट्रीट करना है कि ट्रीट नहीं करना. कमिंग टू फिजिकल एग्जामिनेशन, अगेन दिस इज वेरी इंपॉर्टेंट. कोई क्लिनिकल एविडेंस ऑफ एसाइटिस, पेरिफेरल स्टिग्मेटा ऑफ लिवर सिरोसिस है नहीं है. एंड ऑफ कोर्स जब इन्वेस्टिगेशंस की बात आती है, डजंट मीन कि ओनली वन इन्वेस्टिगेशन. इट्स वेरी वेरी इंपॉर्टेंट. द बेसिक इन्वेस्टिगेशन फॉर ट्रीटमेंट ऑफ हेपेटाइटिस बी इज टू नो द लिवर स्टेटस. इसका पिवटल रोल है और ये हमें नहीं भूलना चाहिए. एंड ऑफ कोर्स है यहाँ पे एब्डोमिनल अल्ट्रासाउंड, नॉन इन्वेजिव लिवर टेस्ट. फॉर लैब वर्कअप में ऑफ कोर्स वी कैन डिवाइड देम इनटू वायरोलॉजिकल टेस्ट्स टू नो द को-इन्फेक्शंस एंड बेसलाइन टेस्ट. एब्डोमिनल अल्ट्रासाउंड का अगेन अ पिवटल रोल इन द लिवर स्टेटस है. इट टेल्स यू वेदर द पेशेंट इज सेरोटिक और नॉट, कोई स्पेस ऑक्यूपाइंग लीजन तो है कि नहीं है. और फॉलोअप में भी हमें पता चलता है कि हाउ द पेशेंट प्रोसीड्स. When the liver is normal, the non-invasive tests, they have their role, the APRI, FAB, and fibroscan, and they tell you that ultrasound pe liver may be normal, but the patient may be having advanced fibrosis, significant fibrosis. So for hepatitis B, there are its own values. The guidelines are batate hain. These are the agreed values for F4 fibrosis and F3 fibrosis. And of course, when we come to the lab, we can divide them into three to do the virological test. Every age-based antigen patient must be having the quantification of PCR, E antigen, E antibody, because if at all you are going to stop, this then matters. And of course, if the patient has got the co-infection, then HCV, qualitative PCR. Then the anti-HDV co-infections, and it should be reflex action that when a patient is age-based antigen positive, please do check for anti-HDV, and when anti-HDV is positive, check for its PCR and the lab, baseline lab. So all these when we do, so what we have, history and clinical examination, if there's any evidence of cirrhosis or its complication, abdominal ultrasound showing whether cirrhosis, portal hypertension or liver mass, non-invasive tests, and we should be clear whether my patient is having insignificant fibrosis, significant fibrosis, or the patient has got cirrhosis. And of course, the quantitative PCR, we must be knowing if it is detected or undetected, and if it is detected, what's the viral load, whether this is more than 2,000 or less than 2,000. Having this data with us, now we pursued how to go about. And of course, the LT is very important. Know for male, the 35 is the upper limit, and for the female, it is the 25. So when we have this data with us, then it was easy for us that how we should be whether going to treat this patient or not. So in 2023, the Chinese guidelines came, and even they suggested that it is only qualitative PCR needed, not quantitative. And then came the WHO guidelines, which the famous 4 options were there. Then came the EASL guidelines, and again it tells whether the patient has got the quantification, what much quantification. Then the AACLD, a few months back, again showing the E antigen positive, its own areas, the E antigen negative, the 2 clear areas and the gray areas, and of course so I won't go into detail of these, how we can translate that into clinical practice when sitting in the clinic. What I do personally, I'll be sharing with you that. Patient having age-based antigen positive, first thing, which you should consider. Of course, that data, the viral load, the E antigen status, and liver status, is with us. But whether this patient needs, there's reactivation of HBV warranted or not. And most patients, they are referred to us whether they are going to be started on immunotherapy or this rheumatoid or something like that, and they ask what to do if they are HBs antigen positive. Even in this scenario, if the patient needs that, the prevention of reactivation is because once hepatitis B, always hepatitis B, lifelong hepatitis B. Even HBs antigen negative patient can reconvert. HBs antigen may become positive. So when HBs antigen is positive and patient is going to undergo these sorts of drugs, if it is yes, this patient needs treatment. So this is the first step. If there is no need for the prevention of the reactivation, then comes the second option, and that is the liver status. If my patient liver status has got cirrhosis, or the patient has got HCC, or the patient has got a liver transplant patient, if he falls in this category, again, he needs treatment. Here the viral load and the ALT becomes irrelevant. But if liver status is okay, there is no F4 fibrosis or other grave liver statuses, so then here comes the role of the hepatitis B viral load and the ALT. My patient doesn't fall in this first class or in the second. Normal liver or F1, F2, or maximum F3 fibrosis. No need for prevention of the reactivation. No, the deciding factor is the viral load and the ALT. And the Chinese, they said just positive PCR in a raised ALT. Double SLD said for EHB antigen positive, 20,000 units for the E antigen positive with ALT more than 2 times raised, or for E antigen negative, 2,000 viral load with ALT just raised above the upper limit normal. The WHO, again, they said the 2,000, considered that figure with raised ALT. EASL, again, 2,000 with ALT. Personally, I follow this figure of 2,000. It's simple and it's easy to implement. So, in this stage, as I said, this is the viral load and the ALT which matters. And 2 M's. My patient ALT is more than 2 times, is raised with viral load more than 2,000, or the patient may be the PCR undetected, whatever ALT is there. These are the 2 clear indications, or clear scenarios. So for the first scenario, when the viral load is more than 2,000, ALT is raised, this patient needs treatment. On the green side, whatever ALT is there, but the PCR is negative, patient needs to be put in the follow-up groups and see follow-up every 6 months that whether the patient needs treatment later on. But things don't follow like this. It may be viral load over the 2,000, but the ALT normal. And most of our cases fall in this class, or viral load less than 2,000, ALT is raised. The third scenario possibility is viral load less than 2,000 and ALT normal. So green, red, they are the clear. What about these yellow, the gray zones? And this is the terminology, this is the AACD guideline is saying, shared decision making. You then individualize the therapy, the decision whether I should treat this patient or not. How we go about that, and these are covered by the guidelines, that if the liver status has got significant fibrosis, F2, F3, all guidelines, the Chinese, the WHO, the EASL, the AACD, they cover this. Or if the patient has got extra hepatic manifestation of hepatitis B, or if the patient has got co-infection of hepatitis D, C, or HIV, or age is more than 40 years for male, and platelet less than 180,000, this platelet figure I have taken from the AACD guidelines, or there's family history of liver cancer or cirrhosis. EASL, Chinese, the WHO and WHO all agree on that. So if any scenario is there with this yellow area where they don't fall in the clear-cut indication to start or clear-cut indication, don't start the treatment. In this, if anyone is there, any scenario of these 4-5 is there, it is start the patient on treatment. But if none of these is there, patient in this that yellow region or the gray area, don't treat, follow up. A time when the patient's cirrhosis, fibrosis gets worsened or any other complication happens, or the viral load increases, the ALT increases, and then the patient qualifies for the treatment. So this is a simple algorithm which you can follow. I follow most of the time this one in your everyday clinical practice. But you should be having all that data with you, which I shared with you, full history, examination, and the relevant and important investigations. Which drug to use? I won't go into the detail. We all know that, the entecavir, we know it's the class, its dose. Important point is it should be taken on empty stomach. So entecavir on empty stomach. Remember that. 2 hours before the food or 2 hours after the food. This is one important point. Preferred drug in elderly and decompensated cirrhosis, but in decompensated cirrhosis, the dose is 1 milligram. And of course, renal sufficiency. For TDF, it may be taken with or without food. So remember this. We know the dose, we know its relationship with the food, and it's a preferred drug in decompensated cirrhosis, pregnant ladies and women of childbearing age. We all know that. And then the TAF, it should be taken with the food. So this is very important. Please instruct your patients for entecavir on empty stomach, and TDF with or without food, and TAF should be with food. They are after food. खुराक ली, after food आप इसको कहें कि आप लें, तो ये आपके लिए easy रहेगा to remember. And we all know that कि अगर हमारा renal impairment है, decompensated cirrhosis है, तो dose modification आपको करनी पड़ती है. The same is, we monitor these patients on treatment, ALT, HBV DNA, ये हम treat करते for HB antigen positive, E antigen और anti-HB, ये हम every 12 months करते हैं. Of course, after virological response is achieved, check HBs antigen every 12 months. जब तक PCR नेगेटिव नहीं है, HB antigen नेगेटिव है, HBs antigen चेक करने की या उसकी वायरल लोड, अगर पेशेंट इंटरफेरॉन पे है तो फिर वायरल लोड अदरवाइज उसकी ज़रूरत नहीं है, ऐसी कॉस्ट बढ़ जाती है फॉर द ट्रीटमेंट. ऑफ कोर्स रीनल फंक्शंस को मॉनिटर करना ज़रूरी है. नॉन सिरोटिक पेशेंट्स का अपना प्रोटोकॉल है, फॉलो अप का, और सिरोटिक पेशेंट्स का अपना प्रोटोकॉल है. वी ऑल नो दैट. जस्ट टू रिमाइंड के ये हमने करना होता है. When to stop? This is very, very important question. And again, what I follow and simple to remember is, if I have started my patient on interferon, it means we have to stop the treatment after 48 weeks. Response किया कि नहीं किया, हमने stop करना है. It's a right. If my patient on oral drugs, F2, F3, F4 fibrosis, again, lifelong therapy. Just like, अगर हम वो cirrhosis में जिस तरह indication was कि जब F3, F4 fibrosis थी, उस वक्त even with negative PCR, we had to start the treatment. F2, F3 थी, और अगर वो even yellow area में था, तो फिर भी हम treatment start कर रहे थे. Once we start the treatment, patient treatment should be lifelong. What about if my patient has got F0 or F1 fibrosis? AVT may be stopped. I'm not saying should be stopped, may be stopped. और यहाँ पे again, shared decision making approach, patients की motivation, patients follow up के लिए कितना regular है, कितना नहीं है. एक patient है वो बोलता है जी मैं टीके बंद कर रहा हूँ, not willing for, और कह रहा है कि मैं regular भी आऊँगा, तो फिर क्या करना है? Again, to make the thing simple, guidelines, plus minus तमाम guidelines इस पे agree हैं. I'll make it more simple for you. अगर पेशेंट्स का HBs एंटीजन, उसका HBs एंटीजन भी नेगेटिव हो गया और PCR भी नेगेटिव हो गया, फर्स्ट सिनेरियो, दिस वन. सो द पेशेंट शुड रिसीव AVT फॉर एडिशनल 1 year. ये ब्लू आप देखें नीचे, पेशेंट का HBs भी नेगेटिव हो गया, PCR भी नेगेटिव हो गया, इस टाइम के बाद मजीद 1 ईयर तक ट्रीटमेंट उसको दें, एंड देन you can stop provided patient is willing for very regular follow-ups. अगर पेशेंट का सिर्फ PCR नेगेटिव है, HbS एंटीजन स्टिल पॉजिटिव है, एंड दिस इज द AACD गाइडलाइंस की स्टेटमेंट है, एंड इज HbS एंटीजन लेवल इज लेस देन 100 यूनिट्स, फिर आप सोच सकते हैं कि मैं ट्रीटमेंट को स्टॉप कर सकता हूं, लेकिन इट डिपेंड्स अपॉन ई एंटीजन स्टेटस. ग्रीन HbS एंटीजन पॉजिटिव है लेकिन लेवल है लेस देन 100, ई एंटीजन नेगेटिव हो गया, ये ग्रीन पे देखें. He was to start with HbE antigen positive. This patient now should receive additional 2 years therapy, and the PCR should remain negative, E antigen should remain negative, and then you can think about stopping. Patient HbE antigen negative था to start with, HbS positive है, but it is less than 100 units. That patient should have additional 3 years therapy. And during all these 3 years' time, PCR should remain negative. Only then you can think about, well, I can stop the patient's treatment. So practically, यहाँ भी lifelong therapy है. अगर ये patient stop करता है, तो this is very, very important. ALT, HBV DNA should be monitored every 1 to 3 months for initial 6 months, then every 3 months for the next 6 to 12 months. Thereafter, monitor at 3 to 6 months intervals depending upon the ALT and HBV DNA values. Treatment should be restarted immediately. These are the AACD guidelines. If any of the following criteria are met, HBV DNA more than 10,000 rise कर गया, regardless of the ALT levels, आपने follow up कर रहे थे. ALT more than 5 times rise कर गया, regardless of the HBV DNA, flare में चला गया. Total bilirubin more than 2.5 हो गया जब आप follow up कर रहे थे. Are any symptoms of hepatic decompensations, restart the patient on treatment. ठीक है? They may be restarted any time for any of the following reasons. Patient wish to restart. Patient ने कहा जी तंग आ गया हूँ जी, मैं क्या बार बार टेस्ट करूँ, दोबारा शुरू कर रहा हूँ. Yes, restart. These are the AACD guidelines statements. एक्स्ट्रा हेपेटिक कॉम्प्लिकेशंस आ गई, या ट्रीटमेंट इनिशिएशन क्राइटेरिया जो आपने शुरू में किया था वो दोबारा मिट हो गया, इन यूर इट मे बी रीस्टार्टेड. ओके, सो जस्ट लास्ट 1 or 2 slides. Hepatitis B in pregnancy, I am simplifying the things. Pregnant ladies already on treatment for hepatitis B. एक सिनेरियो ये है, ट्रीटमेंट पे थी, प्रेगनेंसी हो गई. If she is on entecavir, it should be changed to TDF preferred or TAF. If she is on TDF or TAF, it should be continued as such. After delivery, HBV vaccination or hepatitis B immunoglobulin, यह बच्चे को देंगे. Otherwise, treatment will remain continued. If the second scenario can be pregnant lady with unknown status of HBV infection, antenatal clinic में आई, and these should be screened for that. And she was found to be HbS antigen positive for first of the time. Reflex action है कि आप इसका DNA quantification भी कर लेंगे, बाकी भी देख लेंगे. If the patient qualifies for antiviral treatment, you start the patient at TDF preferably or TAF as a standard protocol. अगर patient does not qualify for the antiviral treatment, और इसका viral load is more than 200,000, तो यहाँ पे आप उसका मदर टू चाइल्ड ट्रांसमिशन इंडिकेशन में ट्रीटमेंट स्टार्ट करेंगे, प्रेफरेबली 28 वीक्स ऑफ प्रेगनेंसी, क्योंकि इस वायरल लोड पे ट्रांसमिशन के चांसेस ज़्यादा हैं. एंड ऑफ कोर्स वैक्सीनेशन हो जाएगी, एंड आफ्टर डिलीवरी न्यू बॉर्न शुड बी गिवन HBV and HBV वैक्सीनेशन. इफ मदर इज फाउंड टू बी HbS antigen पॉजिटिव बाय ELISA एट द टाइम ऑफ डिलीवरी, डिलीवरी के लिए आई, कोई उससे एंटीनेटल क्लिनिक नहीं था उस वक्त, अब चंद घंटों में डिलीवरी हो रही है, फिर क्या करना है? गिव द न्यू बॉर्न HBV वैक्सीनेशन, वी डोंट नो क्या स्टेटस रही है. Check the mother HB antigen and NHB and ALT and DNA quantitative PCR. If she qualifies for treatment, start the patient on treatment. If she does not qualify, to start her on the TDF or TAF till completion of infant HBV vaccination or prevent mother to child infection. Double SLD बोलती है कि after delivery अगर आपने mother to child transmission prevent करने के लिए यदि आप stop कर दें. Like that, we agree we should be giving till the completion of the at least 3 doses of the HBV vaccination to that infant. Scenarios which I have not covered and that can be discussed in our discussion. How to treat HBV in children 2 to 11 years old, ये मैंने touch नहीं किया. How to treat patients with acute hepatitis B, ये भी touch नहीं किया. How to treat BD co-infection, D पे हमने lecture सुना तो probably mostly ये वहाँ पे cover हो गया था. How to treat HBV HCV co-infection, ये भी मैंने नहीं किया. We can discuss this in the discussion. And how to treat HBV in patient with dialysis and kidney transplant. और ये बड़ी नाशुक्री होगी कि अगर मैं अल्ताफ़ साहब का शुक्रिया अदा ना करूँ, ज़ैकम साहब का ना करूँ, बाकी मेरे तमाम हैपनेट मेंबर्स साले हैं, ज़िशान भाई हैं, ज़ाहिद आज़म हैं, कि we have been working on these HBV guidelines for the last 2-3 years. जब चाइनीज़ आई हमने इस पे काम करना शुरू किया. हर साल एक नई गाइडलाइन आती है, हम उस पर फिर फाइन ट्यूनिंग करते हैं, फिर नहीं आते, फिर फाइन ट्यूनिंग करते हैं. So this all algorithms and all discussion was really I had the tremendous and very enormous help from the Altaf Saab and all my colleagues. So once again, thank you very much, sir. This was all possible because of you. And as I said, कि हर साल हम अपने प्रोटोकॉल में चेंजेस करते रहते हैं और शायद आगे भी चलते रहेंगे. Thank you very much for your kind listening.
Thank you so much, Dr. Professor Faruqi, for such nice, wonderful talk. Going forward to our next presentation, she is an online presentation through the Zoom. And the topic of presentation is the palliative care in the cirrhosis, role of the hepatologist and the palliative care physician. And it will be presented by Dr. Amara Naveed. She is a consultant hepatologist at the Pakistan Kidney Liver Institute, one of the leading transplant centers in Pakistan. So Dr. Amar Naveed will join us. Thank you.
Assalamu alaikum, everyone. Can somebody please confirm that they can see my slides and hear me? Can I ask someone in the audience to confirm if they can see my slides and hear me?
Yes, Dr. Amara, we can see your slide.
Okay, perfect. Thank you very much. Thank you, everybody, to the organizers. Thank you for giving me the opportunity for presenting today. My apologies for not being able to present in person. Over the next 20 minutes, I'll be talking about palliative care in liver disease and what the role of the hepatologist can be in providing this particular care. So liver disease presents significant burden globally. It's the 11th most common cause of death, and there are significant regional variations that are seen. The Eastern Mediterranean region is the most affected, and it's the 5th most common cause of death in that particular region. Overall, worldwide, 1 in 25 deaths are secondary to liver disease, and these particular deaths are more so in males, and only 1 out of 3 females worldwide die from liver disease. However, this is in contrast to kind of the data reported from Pakistan. Studies by WHO in 2021 reported that females actually are dying more of liver disease compared to their male counterparts. And I wonder if this is just kind of more reporting or underrepresentation of females and females presenting at advanced disease because of a lack of access to care in this particular population. It's important to note that not all patients with liver disease have kind of the same survival. So patients with compensated liver disease survive much longer compared to their decompensated cirrhotic counterparts. And also important to note that decompensated patients, if treated appropriately, can recompensate. So we've seen a lot of patients with hepatitis B, hep C, HIV, and alcohol liver disease who present pretty early in their disease course, and if treated appropriately, actually can have a significantly better survival compared to those that remain untreated. Not everybody, or not every decompensation presents the same way, and patients don't have the same outcomes. So if your patient present with ascites, there's a 20% chance that they're going to die within the next year. But if your patient is presenting with a variceal bleed, there's more than a 50% chance that they're going to die within the next year. So important to kind of understand not just liver disease, but kind of the kind of decompensations that they're presenting with when you're prognosticating your patients. Interestingly, the trajectory for liver disease, especially in decompensated patients, is very different from those with solid cancers. So patients with solid cancers kind of have a slow downward trajectory towards their death, whereas patients with liver disease will have these episodes of decompensation and then they will get better. And this betterment that they have improves their functional status, but they never go back to their baseline. And so this is kind of something that we see in clinics kind of overall, that you have a slow decline, but you have these episodes where patients get really sick, but then get better. And this provides kind of false hope to the patients and their families every time that they come to the hospital, that they're going to get better and that they're going to go home. And this also makes it kind of a little bit difficult to prognosticate patients. And if you prognosticate end of life care over here, patients will kind of not have faith in the whole system, and it's then difficult to have these conversations further down the line. What's important to note that liver transplant does offer curative treatment for patients with decompensated liver disease, and I have an issue in this particular diagram that liver transplantation is being offered late in the course of disease. We generally do want to see patients much earlier, and ideally we should be referring patients when they have their first episode of decompensation. Otherwise, something that we're seeing very frequently at PKLI is that patients are referred very late, and we have a very narrow window to transplant them. And sometimes, despite having all the resources, having a donor, we miss our window of opportunity to transplant our patients. In terms of the burden of decompensated liver disease in Pakistan, this was a good publication recently published in a local journal in Pakistan that looked at kind of the decompensated spectrum. It looked at prevalence, etiology, complications, and mortality. What it showed was, it looked at all of the publications from 2000 to 2023. Data was reported on about 20,000 patients all across from Pakistan. There is a male preponderance, so almost 3 times more male presenting with decompensated liver disease. 1/4 of the population is very young and younger than 40 years of age. 50% of the patients are illiterate. More than 2/3 of these patients reside in urban areas. And not surprisingly, hepatitis C is the most common cause of decompensated liver disease, with 61% of the patients presenting with this particular cause. Hepatitis B, MASLD, and alcohol remain some of the other top etiologies of decompensated liver disease. Not surprisingly, this is something that we see in our clinics as well. Patients are presenting very late. So 50% of the patients, when they present, have stage C or child class C liver disease, and only 12% present earlier with child class A cirrhosis. Mortality is surprisingly high in our part of the world as well, where 30-day mortality is reported at 22% in this paper, and a 1-year mortality of about 50%. So a lot of these patients actually present very late, and so palliative care, in the end, ends up becoming end-of-life care, which is not the same concept as I'll discuss towards the later part of my presentation. So what is palliative care? Palliative care is care that aims to optimize the quality of life and alleviate the suffering of patients with serious illness. Initially, it was thought that palliative care could be provided only to patients who had advanced disease or in which curative intention was kind of not the goal. But now with palliative care services improving across the world, the palliative care services are now also being provided to patients in which you're treating them with curative intent. And who can provide this particular care? It is said that any member of the care team, whether it's a primary hepatologist or a primary care physician, can provide this particular care. And if you have more complex cases, then you can have subspecialty referrals in people who are trained specially to provide palliative care. What exactly do I mean when I say, provide palliative care to patients? So there are 8 domains of palliative care that have been established, and I think we as physicians are very good at looking at the physical aspects and the psychosocial, psychiatric aspects of care, but there are several social, spiritual, cultural, and end-of-life care aspects that kind of get ignored. It's important to note that end-of-life care is not all of palliative care, like I said before. So hospice or end-of-life care is only a particular domain within the palliative care services. Hospice or end-of-life care is offered to patients who have limited life expectancy, and it's generally said to be less than 6 months. Hospice care is goal-directed and kind of only focused at comfort, and there's no associated aggressive medical therapies that can prolong life provided at the same time. However, in palliative care, it can be provided at any stage of liver disease. It's goal-directed, not just for comfort, but other symptoms as well, and other aspects of social care as well. And it can be given at the same time when you're giving aggressive medical care. There is a general lack of palliative care services in Pakistan. According to an atlas of palliative care in the Eastern Mediterranean region, there are about 800,000 patients that are eligible for palliative care in Pakistan, and we're providing care to only less than 1% of these people. When it comes to hospice or palliative care services, we are labeled as a Class 3A nation, meaning we have isolated palliative care provisions rather than it being integrated into our healthcare system. And we are the least favorable in terms of having the lowest patient to facility ratio for end of life care, where we're offering only one service to over 160 million people. So definitely services are very, very limited. One of the biggest issues is that when you look at the Western literature, palliative care is well defined, but the palliative care concept in Pakistan is very different because of a difference in the socioeconomic factors, cultural and religious beliefs, and kind of the segregated healthcare system, which is the private payer model that we have. And so there's several barriers to care, that our patients and our physicians, come across. Some of the biggest things that I personally struggle with when it comes to palliative care is advanced care planning. You say that you have to provide palliative care to the patient, improve the quality of life, but sometimes having these conversations with the patient is very, very difficult because in our culture, talking to the patient about death is something that is kind of considered a taboo. If you talk to elders about death, it's considered disrespectful. It's considered that you're giving up on your patient. The Western literature focuses a lot on patient autonomy, where the patient is deciding, the patient is telling you kind of what to do. So when you're delivering this particular kind of care in which you're trying to improve the quality of life, the question is, how do you do it in the Eastern context? And this concept of family autonomy, where the family makes the decision, is something that is well documented. So you really have to not just look at the patient, you have to look at the family, talk to the family, see who within the family is going to be making those decisions, and if the patient wants to be part of the conversation or not. I was trained in the West and it was all about the patient making the decisions. And I had a very hard time, when I came back to talk to families and not to the patient. But I realized that not every patient actually in Pakistan does want to talk about palliative care or end of life care. But when they do, it's difficult for us to open up for the families and for the physicians as well to open up and ask who among our patients wants to be involved in this particular care. And so some of the simple questions that you can ask your patient is, do you want to know about your disease? And you will be surprised, a lot of patients do say that they want to be part of the decision-making process, and a lot of the patients will tell you, no, talk to my family. So I think, one simple sentence can put everybody at ease about who this person is going to be, who's going to be making decisions. And then you ask your patient if they don't want to be part of the decision-making process, who would you like to make decisions on your behalf? And almost everybody, will tell you who they want decisions, who do they want making decisions on their behalf. A lot of times what I see in my liver clinic is that, somebody who's street smart, not necessarily related to the patient, is sitting next, to the patient in the clinic, because they're the ones that have helped navigate the patient coming from an urban area, into Lahore, and then navigating all of the requirements of the hospital to come see us in clinic. So a lot of times when we're telling something to the family members, it's not that particular family member who is going to be taking, care of that particular person. So it's very important to identify who the decision maker is going to be and who is that person that is going to be providing care to that particular patient. Our patients have a lot of symptoms, ascites, edema, confusion, things that we're very well equipped with managing. And then there are a lot of other symptoms associated with a poor quality of life, like fatigue, insomnia, things that kind of we're a little less familiar with. And over the next few slides, I'm going to talk about those symptoms and how do we approach them. So one particular approach that was used in patients with PBC was the TRACE approach, and now it is being utilized by almost now it is being utilized across all spectrums of the symptoms that the patients with liver disease have. And the approach is, a simple TRACE approach in which you treat the treatable, you try to ameliorate the symptoms as much as you can, you give patients coping strategies, and you empathize as much as you can. So this is a four-pronged behavioral approach strategy that has been shown to improve quality of life in our patients. We're good at managing symptoms associated with liver disease. So we can identify reversible causes of hepatic encephalopathy, and we should do that. We need to educate patients about early treatment. If there's early signs of hepatic encephalopathy, start treatment right away. We should tell patients to optimize bowel regimens, 3 to 5 bowel movements a day. And lactulose, which is the mainstay of treatment, can be supplemented or traded off with polyethylene glycol. If patients are having excessive bloating, or some patients might have nausea associated with the use of lactulose. When it comes to variceal bleed, the timing and need for endoscopy should be individualized, as not all patients will be candidate for endoscopy, and especially towards the end of life, it is better to kind of manage these patients symptomatically rather than putting them through invasive medical procedures. When it comes to ascites or hepatohydrothorax, optimizing the dose of diuretics is something that needs to be done. Most of the times, we are good at optimizing diuretics. However, there are some patients who have significant ascites and edema in which the diuretics can be pushed further without any side effects. The other thing is utilization of TAPs as needed and symptomatic paracentesis or thoracentesis to alleviate patient's symptoms. When it comes to refractory ascites, we can carefully consider TIPS. However, most of our patients are frail, elderly, and they have borderline liver reserve, and so not a lot of patients will become candidates. But I think if your patients are presenting early with ascites, variceal hemorrhaging, they're not transplant candidates, early referral for TIPS should be something that one should consider. In patients who are requiring TAPs very frequently, abdominal trains can help alleviate some of their symptoms and provide a good quality of life. Tunneled peritoneal catheters are used in the West. However, they're expensive and not readily available in Pakistan. And we at PKLI will, use a regular pigtail catheter, especially for patients who require weekly paracentesis and are towards the end of their life, because these can be cheaper alternatives and provide a very good quality of life to your dying patient. Pain control is a significant issue in our patients with cirrhosis. There are certain non-pharmacological options like heat-cold patches, physical therapy, meditation that we can use, and a lot of other pharmacological options that are reported in literature. However, unfortunately, there's limited access to these medications in Pakistan. Medications like fentanyl patches, hydromorphone, and oxycodone are the preferred agents for severe pain, but secondary to restrictions of opioids, there is lack of access to these medications for our palliative care patients. Anytime that you're using the WHO, anytime that you're treating pain, please do use the WHO analgesic ladder, in which you use non-opioid analgesics for mild pain, weak opioids for moderate pain, and then reserve the strong opioids for severe pain. And always use a multimodal approach, meaning along with your non-opioid analgesics or your opioid analgesics, you can use other adjuvant medications like gabapentin, pregabalin, and some cases short doses of steroids, especially dexamethasone, can help patients who have large HCCs. Unfortunately, like I said, for severe pain, while the recommendations are to use hydrocodone and fentanyl and other strong opiates, we in Pakistan are only limited to the use of tramadol, 50 milligrams every 8 hours as needed, to pentadol, 75 milligrams every 12 hours, and pain remains a significantly unaddressed area for our patients. Some patients will present with fatigue. The contributing factors underlying should be assessed, for instance, hypothyroidism, depression, adrenal insufficiency, anemia, vitamin deficiency, and sometimes medications can cause these side effects as well, especially like beta blockers, something that most of our patients are on. A lot of our patients are given unnecessary dietary restrictions. So I've seen a lot of patients complain of fatigue, a poor quality of life. And if you ask them what they're eating, they'll tell you they're not really eating much, and just improving the kind of and the quality of food that they're taking does create a significant impact. Physical exercise has actually been shown to reduce fatigue, and this is something that we don't really encourage that much in our patient population. I think should be encouraged a lot. So for those patients that are fatigued, asking them to get up, exercise, work with a physical therapist may ameliorate their symptoms. And there's actually no data to support the use of stimulants in patients who have decompensated liver disease. Our patients may also have a lot of muscle cramps, secondary especially to the use of diuretics, so correcting their underlying electrolyte abnormalities, the use of zinc sulfate, baclofen, Nubrol Fort, and methocarbamol can be something that can ameliorate their symptoms. Pruritus is one of the most significant complications I think that a liver patient can have, because pruritus is sometimes very difficult to alleviate and causes a lot of distress to our patients. Some non-pharmacological therapies that we can use are moisturizing creams, avoid hot baths and harsh soaps, use a lot of emollients, use loose fitting clothes, and patients can use like cool humidified air if they have access to, to such things. The other pharmacological therapies that can be done are cholestyramine, sertraline, antihistamines can be used with, sleep-associated disturbances as well. And so any of your patients that have pruritus, providing antihistamines, does become a backbone, but can be specifically helpful in patients who have significant sleep disturbances. Moving on from symptoms of the patients, one particular aspect of palliative care is also looking at the caregiver burden. And I think this is something that is most often, not addressed in our part of the world. Caregivers have a lot of psychological, physical, and financial burdens. They report a lot of stress, anxiety, depression, insomnia, and decreased health related quality of life. And they have a worse physical health compared to those that do not provide care to patients with chronic illnesses. And a lot of these patients or a lot of these caregivers feel unprepared. They are unprepared to provide physical care, they're unprepared for medical management, and especially transportation of the patient to and fro the hospital. And the question is, how can one help the caregiver? There's unfortunately not a lot that we have access to in Pakistan. However, just inquiring about how the caregiver is doing during a medical visit and acknowledging the challenges of caregiving can provide some relief to the caregiver about the emotional distress that they're feeling, because some of them think that it's their duty and they get very anxious with the stress that they feel. However, in the West, services that are available to caregivers are spiritual support, mental support, bereavement support, grief counseling, and peer support. And I really wish, we could establish something like that for our caregivers as well. Some of the last slides of my talk are talking about, the dying patient, this concept of a good death. So the West has kind of evolved and talks about a good death, and this is something that is still a taboo subject in our part of the world, especially with our patients. But a good death, or providing somebody a good death, means to help people who are dying have peace, comfort, and dignity at the end of their life. And there are 12 domains to a good death that have been reported in literature. A study was done in Islamabad, in Rawalpindi, in one of the hospitals, and they looked at 110 patients in Pakistan. 68% of them were male. They were divided into two groups, one patient and two healthcare providers. They were ages 20 to 79, and almost all of the patients were cancer patients who had active stage of cancers and were on active treatment. And they looked at these patients and gave them these 12 concepts of a good death. And it was interesting was that the Pakistani population actually did resonate with 8 of these particular components of a good death. It was reported that while not a lot of patients want to know the timing of death or want to control the treatment process of death, almost 100% patients want to die with dignity. They want to know where death occurs, and they want to control kind of who is around them at the time that they're dying. They want spiritual support. They want to leave a will for those that are left behind or those that are bereaving. And they want to complete their unfinished agendas of life. And they are concerned about the security of their family once they are gone. So I think while we don't have conversations about death with the patients, and I think it's challenging to bring up this subject, I think sometimes what we can do is ask families if their deaths can be managed at home. If the family member prefers death to happen at home or in a hospital, and if it is a hospital, link them to an appropriate facility that can handle the burden. We don't have a lot of inpatient or we don't have a lot of inpatient hospice facilities for sure. And even hospitals are not catered to take care of end-of-life care patients. So I think developing linkages within your referral centers to ensure when you refer such a patient, they will be taken care of is crucial. Ask the family members who will be around at the time of death, and any support that other family members can ask. Recommend a shared care with other family members so that a caretaker burden can be alleviated. And for large-scale centers, like PKLI, we're trying to develop dedicated phone lines that are trained by nurses, that are manned by trained nurses and medical officers, so that support can be provided to these patients through a phone call. My last take-home points, my last slide, is that palliative care aims to optimize the quality of life and alleviate suffering of patients with serious illness. It can be provided by any member of the care team. It is influenced by cultural, socioeconomic, and religious norms of the individual and society. There's a dire need to upscale access to care across all domains of palliative care in Pakistan. And the best approach, to managing systemic symptoms in your patients would be to treat what you can, ameliorate, cope, and empathize with your patients. Thank you very much.
Thank you so much, Dr. Amara, for a nice presentation. For the interest of time, we take the question at the end of the last talk. So our next presenter is Dr. Mohammad Saleh. He is a consultant hepatologist at the Shifa National Hospital. He's our teacher, our mentor, and he will present on the management of the very important topic, management of hepatitis B, C, pre, peri, and the post-transplant. Thank you.
Thank you, Asif, for a nice introduction. Thank you, Feroz Sons. So we will be, I will try to be brief and simple. That's the only one thing which I can say that I'll try. We know that the management of the treatment, all these viruses, since morning we are hearing that that leads to liver fibrosis, cirrhosis, and HCC. And then you need liver transplant to help these people. But can we treat these patients? Can we avoid them? And even if we are going for liver transplant, how we can manage these patients before, during, and later on. So for HBV, we know that in the pre-liver transplant HBV management, we know that antiviral treatment is necessary for all patients diagnosed with advanced fibrosis, cirrhosis, and decompensated cirrhosis. So whether the F4 fibrosis onwards, even if the HBV DNA is negative, you should treat them. We also know that prolonged treatment will lead to virus suppression, leading to regression of advanced fibrosis and even cirrhosis at times. Treatment with nucleoside analogs has shown survival benefits. And for patients waiting for liver transplant, you should treat these patients because to keep them stable and prevent worsening. We also, Dr. Faruqi referred to this, 0.5 milligram per day is the routine dose, but 1 milligram dose is preferred, and specifically in the decompensated liver disease, or if the patient has previously used lamivudine. We also know that with the availability of the staph, it is preferred over the TDF as it is more concentrated in the intrahepatic concentration or more, and it is a favorable side effect profile. So when we treat these patients pre-liver transplant, we know that, and why we treat them, that there is a direct correlation between the HBV DNA levels at the time of liver transplant and the rate of recurrence. We know this is a known fact. And also, HBV treatment along with post-transplant prophylaxis has resulted in HBV recurrence rates from almost 100% to less than 10%. We know that before the advent of this lamivudine and the combination of lamivudine and Shishbig, it was almost like people stopped sort of doing liver transplantation for these patients almost, because they would have it. And since the lamivudine and combination of lamivudine with Shishbig changed the indication, or the liver transplant has become now routine. Is combination of nucleoside, nucleotide beneficial? We know that sometimes you need to rapidly control and have a decline in the HBV DNA levels, specifically in ACLF, and if the pre-liver transplant HBV DNA is high. So at times one may combine even entecavir with tenofovir for that matter. And this also helps not only that the viral DNA levels would go down, but at the same time, they lead to decrease in the risk of recurrence, as we know that the level of DNA is associated with the recurrence. In ALF, you should start promptly, as soon as there is an hepatitis B core IgM positive or hepatitis B surface antigen positive, send the DNA level, start these patients, and preferably on 1 milligram in acute severe hepatitis B or an ALF. Do not delay liver transplant for the nucleoside analogs to work. So you can proceed with whenever the patient needs a liver transplant, because the timing is also crucial, but you should start treatment promptly. Peri-liver transplant HBV management. The intravenous HBIG is given in the N-hepatic phase. We know that in standard practice, the usual dose is 2,000 to 10,000, the more the better. And it is followed by the IV or IM HBIG in the post-transplant period. Not always and not practiced by all centers. We will come to that in a while. Of course, you will continue with the nucleotide analogs, whichever you are giving. Now, the HBV recurrence after liver transplant. We know there are two things. One, the moment you put the liver in and remove the clamps from the IVC and the reverse perfusion occurs to the liver, that's the time of infection. So HBIG neutralizes the HBV DNA hepatitis B virus in the blood, and it neutralizes there. So to prevent infection of the graft, you need HBIG. To prevent inflammation, which is hepatitis, flare, or reactivation of the hepatitis B virus, because that is present somewhere, you need nucleotide analogs. So there are two things. How do we define recurrence? It is reappearance of either hepatitis B surface antigen or detectable HBV DNA, or both. We will come to that, why we are saying that or detectable HBV DNA, because one can have detectable HBV DNA levels even in the absence of hepatitis B surface antigen positive post-transplant. HBV DNA checking is essential even if HBV is negative, because the S mutations may occur, and this is more true when you're using these medications, like the combination of HBIG with the nucleoside analogs. The mechanism of HBV recurrence after transplant includes how it occurs. Like there is high viral loads, and there is saturation of the HBIG by the high viral load. So there are some viruses which are not neutralized. And then there is emergence of antibody-induced escape HBV mutants, and mutation in the hepatitis B surface antigen, surface antibody escape mutations would occur, and that's how you need to check for the hepatitis B viral DNA as well, not only hepatitis B surface antigen. How they present? The recurrence present as an either acute hepatitis or chronic hepatitis. There will be deranged LFTs, or chronic hepatitis, there will be some fibrosis along with that if it's more than 6 months. And it may even present as an ALF, as acute liver failure, or the sinister of all these is also, along with the ALF, is the fibrosing cholestatic hepatitis may present like that. So who are at risk for recurrence? So we know that for sure that hepatitis B E antigen positive patients, because we know that they have got high viral loads, and HBV negative status, HBe antigen negative status with the high DNA presence, or if there are nucleoside analogs or nucleotide analog resistance species, the RAS are present. So they are also predictive of the recurrence. Recurrence rate at 5 years was 15% in E antigen positive, while it was a bit lower if the E antigen is lower, because you know that the viral load is usually low in HBV antigen negative status. The presence of HCC also contributes, and HCC recurrence after liver transplant also affect HBV recurrence. So these patients are at more risk if they have got an HCC. Now, how to prevent HBV recurrence? So we use the HBIG, and we use nucleotide analogs, and of course, combination is always better. So we can use both at the same time. We will come to that, how to use them judiciously. Despite removal of the liver, because we know that the whole of the main burden of hepatitis B is in the liver, the cccDNA, the genome, everything is there. So if you remove the liver, the burden is removed, but still there are extra hepatic sites, such as lymph nodes, spleen, and other organs. They would have they would have this hepatitis B, and this latent virus gets reactivated because of the immunosuppression regimen after liver transplant. And that's why these patients are kept on nucleotide analogs lifelong. Now, we know that HBIG is a polyclonal antibody. It blocks receptor involved in the exportation of the viruses from the extrahepatic site, along with the formation of immune complexes, and result in neutralization of the viral particle. They are good in short term, but may not be in the long term because they're expensive, not readily available. It's an indefinite therapy, and of course, one may develop HBIG resistant mutations. They're not that freely available even at times, and they're expensive. Nucleoside monotherapy with lamivudine and adifovir were effective in reducing HBV recurrence. However, there were issues in the long term as they have got low genetic barrier to resistance. We don't use these two drugs nowadays. Entecavir, as it has high genetic barriers to resistance, the recurrence happened in 16% at 8 years. So it was like a good drug for that matter. And HBs antigen positive patients with monotherapy were 10% at 2 years of follow-up. So it's around, so even at times you may use if the HBIG is not available or there's financial constraints, and we will come to that when we can make sort of this decision. Now, this is if you look at this study from the Subhash Gupta's group with Manav, so it was like the patients with HBV DNA level less than 2,000, they were not given HBIG. We are talking about HBIG later on. All of these patients would receive HBIG during the N-hepatic phase. And patients with HBV DNA level more than 2,000 were given HBIG, and recurrence was defined by the HBV DNA positivity at six months. So they concluded that HBIG prophylaxis with oral antivirals and without HBIG is safe, effective, in the living donor-related liver transplant, and a majority of patients will clear HBs antigen and may even develop antibodies. So, and the patients were, the number was small, and then it was followed by another study. We'll come to that in a while, but I think probably we missed that or what? No. So the combination therapy which HBIG with nucleoside is associated with very low recurrence rates after liver transplant, and several large meta-analyses have shown that combination therapy is associated with reduced HBV mortality compared to HBIG alone. Now, what they used was, this is a study from the Australia and New Zealand, Peter Angus, and this was lamivudine plus low dose 400 or 800 intramuscular HBIG were used weekly from transplantation and then monthly thereafter, and they concluded that the lamivudine and low dose HBIG treatment prevents post-liver transplant recurrence of hepatitis B and is likely to be more cost-effective than the high-dose HBIG regimens. And then it's followed by this at Gans paper, and then they used, it was a large study, and the low-dose intramuscular HBIG plus lamivudine provides safe and effective long-term prophylaxis against recurrent HBV and less than 10% of the at less than 10% of the cost of high-dose regimen. And if you look at there, the recurrence rate was 1% at 1 year and 4% at 5 years, so pretty much acceptable. This study from the India again by the Soin group, and they had a pretty large number. And what they did was all the patients received 10,000 international units in N-hepatic phase, and then followed by 600 to 1,000 intramuscular for 7 days, and then weekly for 3 weeks, and then monthly. And they tried to keep the hepatitis B surface antibodies more than 100 for 1 year. And then they look for the recurrence. And only 2 patients had, one was non-compliant and the other had a proper recurrence. So out of the 43 mean follow-up months in 43 months, or from some up to even 117 months, they had some patients, because this was a long study. And they concluded that this enlarged cohort of the living donor liver transplant recipient HBV-related liver disease, use of low-dose short-term HBIG with given high genetic barrier. They used entecavir in this study, so this was a good one, in a substantial lower incidence of HBV recurrence, and even in high-risk patients, those who had more than 2,000 HBV DNA. Now, only nukes alone or with HBIG, many institutions are now shifting towards HBIG-free regimens and patients to be at who are at low risk of recurrent of infection or discontinuing HBIC after a short period of time. And if you look at all these studies, so if you look at the last one, it used only HBIC for 7 days, some for 6 months or 9 months and up to a year. And they had a pretty low HBV recurrence rates. So with combination of HBIC, specifically low HBIC, later on after the anhepatic phase, along with the nucleoside analog, specifically the entecavir or tenofovir, one can manage these patients better. Can hepatitis B core antibodies, like those who had past exposure, grafts can be accepted for liver transplant? Yes, why not? Because large liver grafts from anti-HBC donors can be safely used, and we do use them because up to 40% of the grafts from the Sindh area would be having past exposure, and they are hepatitis B core antigen, core antibodies positive. Preferentially, they should be used in the hepatitis B surface antigen, but we do use them otherwise as well. Of course, in these patients, you don't give them HBIC. As we mentioned, HBIC only prevents the infection. They have already got the liver, which has got a DNA inside the genome and CCC DNA. So you don't give them an HBIC. But of course, lifelong prophylaxis with nucleoside, nucleotide analogs is given. HBV treatment summary: compensated, decompensated cirrhosis, start them on high genetic barrier nucleoside analog. Improvement, of course, you continue with them. Transplant indication: once decompensation occurs, RECC is there, you give them, you transplant them, and lifelong high genetic barrier nucleoside analogs are given. Considering HBIC also in patients, specifically those are high risk for HBV recurrence, like they have got RAS or high HBV DNA at time of transplant, or if they have got co-infection or they have got HCC. Moving on to the HCV, we know that HCV infection recurs in all patients with HCV viremic patients at the time of, if they have got at the time of transplantation, if the HCV viremia is there, so they would have a recurrence. Difficult to differentiate between at times between the T-cell mediated rejection and HCV infections, and be mindful of one thing: this fibrosing cholestatic hepatitis C may occur after liver transplant, though it's rare, but still you should be watching for it and needs treatment early and promptly. In the pre-DAS era, SVR rates were poor even when we would treat these patients. But however, with the DAS, now we have got up to 90% of the SVR rates. Suboptimal SVR and tolerability were main issues. We know that for sure before the DAs, the availability of DAs leads to remarkable improvement in SVR rates. And HCV treatment, we also know that if you can achieve SVR, it will translate into all-cause mortality as well as reduced liver-related mortality. So treat them if you can. Now, these data demonstrate an association between the DAs and reducing listing rate for HCV-related cirrhosis and HCC. So DAs have changed the scenario. So treat them if you can, and treat them before advanced fibrosis. That's why we say that Dr. Asad was referring to that, find the missing millions, and we should test, screen, and then treat. Now, delisting delisting can occur? Yes, why not? The study showed that all oral DAs were able to reverse liver dysfunctions and favored the inactivation or delisting of about 1 in 3 or 1 in 5 in 60 weeks respectively. And patients with lower MELD scores had higher chances to be delisted. And this study questioned that whether in the long term it will help or not, but in the short term it concluded that it helps. And then the answer came from this study that DAs are safe and effective in patients awaiting liver transplant for cirrhosis and HCC, and a quarter of patients with cirrhosis can be delisted because of clinical improvement. And the dropout rate was over 6.7%, and few recurrences of HCC even after liver transplant were observed. So you need to treat and treat if you can. When to treat and when not to treat, everybody knows that MELD score beyond 27, do not treat. Even in USA, some centers, because of the different UNS regions, 23 melt is the cutoff. So these findings suggest that optimal melt threshold below which decompensated cirrhosis should receive treatment while awaiting liver transplant is somewhere between 23 and 27, depending on the UNOS regions. But if the patient is less than 23, must consider treatment, okay? Specifically if the waiting listing time is more. Now, the categorization by the MELT score, the DA therapy is a systematic review. Decompensated patients must be personalized when considering different factors, particularly the MELT score is more than 18 or 18. So less than 17, definitely treat them. Is this treatment cost effective? And at what MELT it's cost effective? So if the MELT score is 20 or low, it's cost effective. However, post-liver transplant treatment is cost effective if the MELT score is more than 20. However, personalized approach and expert help is recommended in all these patients. Decompensation can occur, so please be careful. Now, word of caution regarding while using protease inhibitor, luckily we don't have them, but still not in decompensated and even in child B cirrhosis. Now, they also say that RAS testing, if not available in cirrhosis, add ribavirin. So ribavirin is a very good drug. Wherever you can use it in advanced fibrosis, cirrhosis, or decompensated cirrhosis, please use it. But we don't have the RAS, so by default, we should use it. Treatment naive genotype 3 with compensated cirrhosis, if we don't go for the RAS testing because we don't have it, so you can have it either prolong the treatment durations or add ribavirin. And daily fixed dose of the other medications which are not available to us can be used for 8 weeks as well. Treatment failures with and or without compensated cirrhosis, so then you need to go to the, add another one to it, which is voxiliprevir, and it's for 12 weeks. Alternative is the one with the glicaprevir and pibrentasvir, but it will be then 16 weeks if they have got previously DAS failures, like soft failure. Decompensated cirrhosis, recommended in all patients with CV who have decompensated cirrhosis, you should be at least, if there is moderate or severe hepatic impairment, should be referred to a medical practitioner with expertise in that condition, and ideally in the, to the liver transplant center. And they should be then deciding whether to treat them or not. So patients with decompensated cirrhosis who have genotype 1 to 6 are ribavirin eligible, added 12 weeks. Even you can use the other ledipasvir and sofosbuvir in non-genotype 3 and 2 patients. Patients with decompensated cirrhosis who have genotype 1 to 6 and are ribavirin ineligible, extended duration to 24 weeks. When to stop? If there is a increase in the ALT level, specifically the sign is wrong, is more than 10 folds, and there are signs or symptoms, stop treatment. Specifically, if the alkaline phosphatase is high, bilirubin is high, and iron is going up, or there is any signs of jaundice or decompensation, please stop treatment. And asymptomatic patients with the high ALT level, monitor them at 2 weeks interval, and if the level remains persistently elevated, consider stopping treatment. CV treatment post liver transplant, a meta-analysis of 22 studies with good number of patients. SVR 12 was almost 90%, and SVR was higher in patients with mild fibrosis when compared to advanced fibrosis cirrhosis. So treat them early post-transplant. These 2 studies from India, they almost had 89 to 93% SVR rates, and they, somehow or other in their studies, the SVR rates for genotype 1 and 3 were similar. Post-liver transplant ECV treatment, naive and experienced patient with genotype 1 to 6 infections of the allograft without cirrhosis, again, treat them as patients like before 12 weeks of the whatever is available to us, which is sofosbuvir, vilpetasvir, or the other one is the glycaprevir and pibrentasvir. Experienced patients with genotype 1 to 6 infection of the allograft compensated cirrhosis, then you can use the same, even if they have been treated previously, you can use the same combination and duration with either sofosbuvir, vilpetasvir, or the other available to, which are not available to us. Now, can we have a HCV positive donor and to an HCV negative recipient? That's a question. Not in a living donor liver transplant, okay? So we do not, would not like to have a liver from a HCV positive living donor. So far we are not brave enough, maybe sometimes, but not yet. But these are in the DDLT things. And they would recommend early treatment with pan-genotypic DAAs is recommended when the patient is clinically stable. And again, the durations and the regimen as there is the soft plus well for 12 weeks. Now, timing of the HCV treatment post-liver transplant, once patient is stable and steady immunosuppression is achieved, you can start treatment. Optimal timing is not clear. However, 3 months seems to be reasonable because by that time, and specifically, you need to document the HCV viremia. Treatment may be started even before 3 months if the patient is stable, and treatment should not be delayed, and specifically in fibrosing cholestatic hepatitis C. Some interactions for us, simple to remember, the soft plus well, they are okay with all the both the CNIs which we use normally. So, of course, there are some data is not available for the TEC and with vilpetasvir, but it's okay. You can use it, and we are using it. HCV treatment summary: compensated cirrhosis, non-genotype 3 and genotype 3, we know 12 weeks. If there is a genotype 3, add ribavirin. If ineligible, then extended durations. After liver transplantation, is 12 weeks therapy. HCV treatment summary: HCV-related decompensated cirrhosis, look for HCC. If HCC is there, go for transplantation. If I'm saying decompensated cirrhosis, okay? And compensated, you can think of other things, because to treat the HCC, and then once HCC is controlled, one may still think of a pre-liver transplant HCV treatment. If no HCC, MELD is 18 to 20 or more, defer treatment after liver transplant. If it is less than 18 or 20, you can go for the treatment. And we know that how to treat these patients, either 12 weeks or 24 weeks. I would thank you all for your kind listening, and would like to take this opportunity to announce that the 42nd Annual Congress of the Pakistan Society of Gastroenterology will be on April 10 to 12, 2026, and it will be at the PC Bhurban, inshallah. Thank you.
Thank you so much, Dr. Saleh, for such a nice presentation. Now the session is open for any questions from the audience. So I have one question for Dr. Farooqi. Like with very nice presentation regarding hepatitis B, but regarding that yellow area, the yellow zone area where the DNA levels are not matched, ALT levels, they are like not up to the for treatment recommendation. What about like if someone has along with the Hep B in this group, along with fatty liver, like the MESLD? Until now, no guideline mentioned about this part like. So what are the recommendations if someone has the fatty liver and fall in this group?
Yeah, thank you very much. Very relevant and very practical and clinical question. Yes, and this is a scenario which we mostly come across. The WHO guidelines did recommend that you start these patients on antiviral treatment. And we discussed this a lot. So if it's only the fatty liver and otherwise it is okay and there is no fibrosis, F0 or F1, that probably we can wait on that, because we discussed this point. When you see this algorithm, what we saw today, this is not what we made this 2 years ago. We had a lot of discussions on it, and Zegam was an opinion that if we include that, that probably the canvas will be so much expanded that probably it may not be, but it should be individualized. Of course, the final decision is by the patient. But I personally think when it's a fatty liver and the high risk, the cardio metabolic risk factors are there, and there is other scenarios, so that patient may be considered for the antiviral treatment. But because that is the yellow or the gray zone areas where you may make decision for one patient to go, and for another you may say wait. So that's the very good point, and needs to be thought twice before starting these patients. So first I'll personally do that. Even we'll try to treat the, minimize the risk factors and treat the weight loss, all those things, and then we can. Thank you.
Thank you so much. So probably by the next year, it may be including some of the guideline, right? So any comments from the chairs, like to conclude the session? But before, yeah, one question here, sir, please.
So again, thanks to Firozans and thanks to Farooqi Bhai, and we have Dr. Altaf and so many luminaries. We'd like to, get some input from them also. Hep C and Hep B co-infection. We recently at our clinic had a patient, HPV, at the time of initiating HCV-DA treatment was negative. This was a patient with a ALT modest range, 45, 46, intermediate sort of HCV count, and we went ahead with the HCV treatment because the HBV PCR was negative. Following successful eradication, the ALT has slightly yo-yoed. It is going up and down. The HCV following DA has remained negative, but the ALT rises, drops a little, then rises. So how often do we get the HBV DNA to check for relapse? Because when we checked, there was some suggestion in the literature that following eradication of HCV, HBV can sort of resurface. So just, comments from everyone. Thanks.
There are theoretically 4 possibilities. One is both are inactive, either C is active, B is inactive, or B is active, C is inactive, or both are active. So when both are inactive, of course, things are simple and you follow them up. When B is inactive and C is active, the general recommendations, and this is one of the guidelines as well, initial one, that when you treat the active hepatitis C during that treatment and 3 to 6 months after the end of the hepatitis C treatment, you give the prophylactic hepatitis B treatment as well. That was one thing, because the cases were reported that while B was inactive and you treated the C, the B was reactivated. So one is that. Second is, of course, when the C is inactive and you treat the B, cases, to my knowledge, no cases have been reported that C has become reactivated. So, but for that, when the patient is having the B dormant and C is active, what I do personally in my clinical practice, I do give them the hepatitis B treatment for 6 months after the end of the hepatitis C treatment. And when that, I don't check in routine the PCRs every 6 months, but if there's a high risk, he's in that group where we didn't start the antiviral. So at least all B carriers, we check the PCR, the ALT 6 months. I personally check PCR yearly. I don't check every 6 months because of the cost and all those things. But for this particular scenario, when B is inactive, C is active, I personally give cover to the prevention of the B reactivation. I'll request Altaf Saab what he wants to say.
Yes, sir. I also, even if DNA PCR negative and HCV PCR is positive, I would treat both. And there is no indication for treatment of HBV. I will stop it 3 to 6 months down the road once hepatitis C treatment is finished. And this is included in the guidelines. On a personal note, Dr. Asif, I would treat MASLD and so-called indeterminate HBV today.
Yes.
Because this comes in the domain of shared decision making, which to me is my decision in Pakistan, because only 1 to 2% of my patients understand the disease pattern, their natural history and all that. And if they do, you tell them that there are 2 fires burning instead of 1. So the risk of damage is higher and earlier. So I would treat you with indeterminate B, but with
Lifestyle.
with MASLD. Whether it is F0, F1, I don't care. So we'll treat for that and take MASLD on merit as we do normally. So, thank you. Yes, yes. And some of the guidelines are now clearly mentioning that in addition to co-infections with B, C, HIV, you know, etc., that you should treat in the presence.
Yeah, I think I agree. Fundamentally, what you basically want to do is prevent the damage to the liver. And if there's already damage to the liver, then you have to do whatever treating B as well as MASLD. So I think personally, if you have a DNA which is there or not there, but if you have a liver damage, in any case, F2, F3 would come in the treatment category. So fundamentally, any evidence of liver damage or inflammation, you just treat.
Thank you, sir.
To me, the liver damage will be fibrosis.
Yeah.
Yeah, liver biopsy may be a good thing here, but that's the reason we say that this is the individualized approach, and of course to the patient and all, and to the caring physician, and how much motivated the patient is for regular follow-ups and all those things.
You will only do a biopsy with the question that you have to answer. So mainly for autoimmune, but for B, for C, for MASLD, now we, even the FDA, Bilal showed that slide, that they advise to do non-invasive monitoring and start treatment based on non-invasive monitoring. So why do a liver biopsy? Except where you suspect either SOL or superad in autoimmune.
Yes, David, everyone has mentioned that biopsy is getting less and less, but autoimmune hepatitis is something we all have seen, and I think that if you have to pay attention to the liver enzyme, and when you start the treatment, liver enzymes are not getting better, you need to treat things. Even in the Respiron clinical trial that's ongoing, there was a case of autoimmune hepatitis. So I think that's the group you have to just pay a little bit more attention to. But anyway, I think that we can end the session. Thank you so much for all the speakers. These were very difficult topics, and they concise it really well. And I think that just want to finish, and thank you, everyone. I think Dr. Abdul, you're going to do the
Yeah, so the key takeaway from Professor Altaf Alam, professor of gastroenterology, hepatology, teachers of many fellows or consultant here, sir. Please, sir, thank you.
Thank you. Kind introduction. Thank you very much, my dedicated friends and colleagues, for staying here for so long. I'm not going to disappoint you. In the key takeaways, I'm requesting the organizers to take permission of the speakers and send the slide sets to all the participants so that even those who have not attended it, and if permitted by the speakers, they can see those slides and even use it in their presentation. It's Sadka Jariya, so why keep it to this treasure to themselves? And that will be the key takeaways for the 12th Liver Summit. It was a lovely program. And just to finish off, I would like to add a few more points to hepatitis B, which in my opinion are important for our setup. So if you have a patient of HBV in pregnancy, where you want to start treatment, it is usually said start in 3rd trimester. But how do we know that this patient is going to go to 40 weeks of pregnancy? She may undergo premature delivery, preterm, or she may develop a problem like ICP, and that may need earlier delivery. Or this particular patient may need invasive procedures like amniocentesis later in the pregnancy. So my suggestion is, in the context of Pakistani population, where antenatal care is rather fragmented, please start early rather than the standard recommendation. So if the standard recommendation is start at 22 to 24 weeks, why not start it at 16 weeks? The other reason I want to highlight for this purpose is that in a country like Pakistan, H-Big sometimes just goes off the market. And there is data to suggest that if in such pregnant females you use hepatitis B treatment earlier, at 16 weeks, you may get away without H-Big and with 0% transmission to the baby. But if you start late, you may transmit HBV to 2 to 3% of children, to the babies. So another important point to consider, especially in our setup, where we have fragmented antenatal care, patients may not show up on time, they may develop complications, may have earlier delivery, and also H-Big may just disappear from the market, and you risk transmitting the virus to the baby. The other thing I would like to say is that sometimes you would like to treat to prevent transmission. So in medical community, if you are engaged in exposure-prone procedures, you are treated. So a doctor who is engaged in exposure-prone procedures as defined by all the regulatory authorities, we need to bring the virus down to very low levels, which in the UK is 200. So even if your viral load was less than 2,000, ALT is normal, and you are practicing as a doctor in exposure-prone procedures, you need to be treated. And the same applies for general population. You know, there is somebody who is going around having multiple sexual partners, maybe engaged in homosexuality, maybe an IV drug addict with shared needles. There you have a risk of transmission. So this adds another dimension to the treatment of hepatitis B. So I sometimes, as I said, the ASLD term, Farooqi Saab, which you mentioned, shared decision-making, to me is your decision-making in Pakistan. Because most of our patients do not understand what we are saying. So I would really take over in these situations and start treatment to a person in pregnancy earlier to prevent transmission. And to me, in indeterminate cases, I would treat either on my own decision making or maybe supplemented by HBS quantitative levels. So I do that frequently and decide whom to start. Most of my patients, I've not seen a low surface antigen quantitative in Pakistan. I don't know where this figure of 100 comes from. All the patients that I have done quantitative surface antigen is more than 1,000, where there is an indication to start treatment. So that sometimes I use in terms of shared decision-making business, which probably does not exist here. The other thing that I would like to say is about stopping treatment. I've been practicing that for many years now, and I would also like to emphasize now the ASLD guidelines have also suggested that in non-cirrhotic, E antigen positive and negative patients do not stop treatment until surface antigen becomes negative. So that question of 3 years of treatment, DNA negativity for 3 years, whatever, don't stop treatment. And your patients will stop treatment, disappear forever. Some of them will develop a flare. Nobody is going to come back for a monthly LFTs and DNA levels. And some of them will die of flare, and others will die of chronic disease and HCC because they will just disappear. But on treatment, they will come back to you. So another important dimension for our setup, that this guideline suits us, that E antigen positive, E antigen negative, surface antigen is still positive, although DNA has been negative, ALT is normal, ultrasound is normal, they are all non-cirrhotics. Continue treatment until surface antigen becomes negative. Otherwise, don't stop. The rest is, Farooqi Saab has very eloquently mentioned all this, and but there were some points that were, going on in my mind. I wanted to just share with you. Of course, some of these are not in concordance with the current guidelines, but it is just a suggestion that you may consider doing what I have said. Thank you very much. Thank you.
Thank you so much, yes. But before concluding a vote of thanks from the Feroz Sons, there's one more, Ms. Paras Hussain, she will present on the GI Connect, right? And then the vote of thanks from the organizers. Thank you.
Assalamu alaikum, all of you. I'm not going to take a lot of time, only 5 minutes I will take. So GI Connect is basically Ferozan's initiative, and its main concept is that how we can work for the more better capacity building of healthcare professionals. So lastly, we launched it at PSH. So its concept is that what we can do and how we can actually create such platforms where our healthcare professionals, specifically in which we are covering gastroenterologists and hepatologists, they can learn more, and because we have many new gastroenterologists, emerging gastroenterologists, and they have many queries and questions. So what we can do that for their capacity building. So here is the screenshot of our website, which is GI Connect. So what are the components of GI Connect? First is the GI core, in which our main core members of this initiative. And then we have Knowledge Universe. So currently, it's one of the tab, which is Knowledge Universe, it's functional. And other is the GI Studio. At GI Studio, we are uploading the different podcasts and which are meant for the treatment. It means different diseases will be discussed in that and their treatments. And we have the knowledge. In the knowledge, we have planned different guidelines and different courses that how what we can do for the further capacity building of healthcare professionals. So currently at the Knowledge Universe tab, what we are providing, that is the free access to Journal of Hepatology, that is EASL Journal, and American Journal of Gastroenterology and JAMA. Plus, you will find different hepatology and gastroenterology books, which are freely available there for download, and the up-to-date monograph data. So I would request that if anyone wants to subscribe, they can simply scan the QR code, and they can also approach through gi-connects.com. So there is no fee, nothing, it's free of cost. And you will find all these things where the data will be available for your access. One is actually updated on the weekly basis as well. And then all books, hepatology books are also available there, so you can download the ebooks. We will also send this with all of you separately on your contact numbers as well. So it's two things. You can access this through the QR code as well, and also if you type this http gi-connects.com, you will reach to the website. मे बी वो साइज का या तो उसके ऊपर इशू हो, लेकिन वो फंक्शनल है. नहीं, इट्स फंक्शनल. आप उसको आप वेबसाइट भी टाइप कर सकते हैं, http://gi-connects.com. मैं आपको ना लिंक शेयर कर देती हूँ इसका. ओके, थैंक यू.
Right. So ladies and gentlemen, thank you so much for making this event successful with your presence. We at Feroz Sons are truly grateful to the entire faculty who put in their efforts to deliver these wonderful sessions. The sessions were indeed very well crafted, and I hope that they have met your learning needs. What I'm sharing here right now is the QR code. We at Feroz Sons strive to make our session better than before. So whatever feedback you will give will help us build a better session for the 13th Annual Summit, inshallah. So please give your candid feedback, your practical recommendations to our team. So next year when we come together on this prestigious platform, we will have a better session for you. And for tomorrow, since the session starts 8:30, I would request an early presence from all of you, because all these sessions are aligned with, I think, EST and UCT timings. So there were some crazy time zones that we had to align. And the entire faculty, our international faculty, is ready to deliver those live lectures. So your early presence is really requested. Thank you so much, everybody.